Hello, I'm Nick Kruger, and I'm going to be talking to you about orthopedic injections. At the end of this tutorial, you should be able to diagnose the common orthopedic conditions that we inject routinely. You should know the safe doses of the common steroids and local anesthetics we use. You should have an understanding of the complications and side effects of injections, and know the indications and contraindications for injections. Some of the indications for injections are for diagnostic purposes, where any fluid aspirated is sent for lab testing to assess for infection or the presence of an inflammatory process or trauma. If you aspirate a joint and you find a hemarthrosis, especially with fatty globules in it, that may represent an intra-articular fracture. Often with an arthritic joint, one will inject a local anesthetic, and if the pain is relieved immediately, that helps diagnosticate that the pain is from the joint. Therapeutic indications include relief of pain or inflammation caused by an effusion, osteoarthritis, rheumatoid arthritis, and gout. Bursitis is another region we inject for pain, and selected tendinopathies. Absolute contraindications for local injections are really infective problems. So if there's suspicion of local cellulitis, if the joint is an artificial joint or prosthetic joint, there's definitely a contraindication for injection. Any systemic infection, septicemia, one should not inject in these cases. If the patient has a fracture, you don't want to be injecting it with steroids. Be very careful about injecting the large tendons, such as the patella tendon or the Achilles tendon. There's enormous forces going through these tendons, and injection of steroids in or around the tendon can cause the tendon to weaken and to rupture, which is very problematic in terms of reconstruction. If the patient has a history to injections, also be wary of this. Relative contraindications. These would include the patient who's anticoagulated or has a coagulopathy. Diabetics. Be wary of these patients. Often the steroids will cause their diabetic control to become uncontrolled. Patients in immunocompromisation, also be wary of them. If the patient's had previous injections with little or no relief, there's no point in doing it again. Local osteoporosis is a concern, and some joints are inaccessible and should not be injected. These include the hip joints and the spinal joints for the general practitioner. Many areas are easily accessible and are commonly injected with local steroids. These include hand conditions such as trigger finger, carpal tunnel, DeQuervains, and basal joint arthritis of the thumb. Many spinal joints are injected routinely under fluoroscopy. Sacroiliac joints are injected. These are slightly more specialized injections and are given in theatre under fluoroscopy with the patient sedated because they're painful. Osteoarthritis is commonly injected, and joints which are accessible include the ankle and knee joint. Hip joints are also injected. Those are easily localizable under ultrasound guidance or under CT guidance with a radiologist. And patients under care of rheumatologists often have multiple small joints injected for routine pain control. Most common large joints injected are the knee and the shoulder, including the glenohumeral joint and the subacromial bursa. Steroids obviously have side effects, and there's systemic and local side effects. The systemic effects include facial flushing, menstrual problems, hyperglycemia. So once again, be careful of your diabetics. It may suppress the pituitary adrenal axis. Patients can become emotionally upset, and there may even be an anaphylactic reaction to it. Local side effects are important. In a small percent of patients, you get a post-injection flare of pain. There may be local skin pigment depigmentation, a subcutaneous atrophy, bleeding in the joint, infections are very rare, but if they occur, they can be catastrophic. One also needs to be wary of steroid arthropathy, where there's chondrolysis, and this is because of certain local anesthetics which are used. Be very wary of injecting around large tendons. Once again, patellar tendon and tendon Achilles, which are absolutely contraindicated for injections for the general practitioner. Another side effect of repeated injections is calcification in the soft tissues. So how frequently? So the concern is that given repeated injections, one can get osteonecrosis or localized osteoporosis. You should really reserve the intra-articular injections for patients who are fairly risky for surgery, patients who don't qualify for surgery, and no more than every couple of months, 3 or 4 a year. There's no really hard evidence about this, but that's a general sort of comfort level for most doctors to not inject more than 3 or 4 times a year. Joint sepsis can occur, and it's fairly rare, 1 in 17,000 to 1 in 77,000, and they can be fatal due to the severe local sepsis, which is uncontrolled because of the local steroids. Commonly used steroids you should need to know are bethamethasone, which is a brand called Celestan Stolispan. It's a local acting steroid, and usually come in 1 cc vials. We can give 6 to 12 milligrams for large joint. Small joints give 1 to 6 milligrams. Another commonly used steroid is methylprednisolone or depomedrol, which is the brand name. These come in 1 or 2 ml vials, and they're 40 milligrams per ml. Just be careful which one you're giving. One has got 2 ml and one's got a 1 ml vial. So it'll be either 80 milligrams total or 40 milligrams total. This is the most commonly used steroid, and others are less commonly used. We often will give local anesthetics with the injection, usually 1% lidocaine. These give rapid onset of analgesia. It's a short-acting local anesthetic. Within minutes you get onset, and it's a very useful diagnostic tool. So if there's some diagnostic uncertainty, the joint is painful, and you inject the joint, if the pain is gone, for instance a rotator cuff, instantly you get relief and one is more comfortable making that diagnosis. Marcaine is also another commonly used local anesthetic. It's slightly longer duration of action, but it can potentially cause chondrocyte death, so do not use it intra-articular. Say it's lignocaine, do not use Marcaine. Other substances which you'll be exposed to on the market are so-called hyaluronic acid. These are a bunch of injectables which include the chondroitin sulfates, which one injects intra-articular, and the effort is to try and so-called replace the synovial fluid. Injecting arthritic knees with this thick viscous fluid, the belief is that it acts like a lubricant. There's a lot of controversy about that. Some people feel it's nonsense, other people swear by it. So just be open-minded about it and aware that it may not work. Explain to your patient you can try it. It's pretty expensive. Those that give it will explain to the patient that they may have 6 months relief, and given in 3 injections a week apart. I'm not particularly fond of it. I don't think there's any rigid scientific evidence about it, but you will be exposed to it when you obviously working in practice, and patients may come request it. In general, before you going to inject a patient, obviously evaluate your patient, decide if there's any contraindications, be clear in your mind what the indications for injection are, educate the patient, consent Think about patient comfort when you're injecting him. Sterile preparation technique, and document. So, get a complete history of the patient. Make sure you've got the right diagnosis, understand what you're going to be doing. Examine the patient, examine all joints, and think of the differential diagnosis as to what you're going to be injecting. If you're doing an intra-articular injection, you need to have an X-ray of the joint. You want to make sure there's not any underlying inflammatory problem or infective problems such as tuberculosis or other conditions or fracture. In those cases, you cannot use steroids, obviously. Educate your patient about the injection they're going to have. Explain to them what's in the injection and what you're expecting the injection to do for them. Be realistic. It's not a complete cure. One is trying to take the edge off the pain. Explain to the patient when they'll notice the effective injection. Warn them that the local anesthetic will wear off after a couple of hours, and it may take a few days for the effects of the steroids to work. It's important. The pain may be back the next day. And also explain what is likely to happen if you don't have relief with injection. So consent can be written. It can be verbal. It doesn't have to be written consent, as long as the patient understands that what the procedure is and the risks and benefits from it. So think about the patient's comfort. If you're doing a knee injection or a foot, they can lie down, or sitting up for the shoulders. Don't rush it. Try and reassure the patient. Try and distract them. Explain how you're going to be doing the injection. And in certain cases, you can put some ethyl chloride on the skin, which may help distract the patient and minimize the anxiety. Injections are often less painful than the patient anticipates, especially if you're doing it correctly. If injection is severely painful, it may be that the needle is not in a potential space. If the needle is actually intra-articular, there's very little discomfort. Also think of your injection techniques. So when you're taking blood, as soon as the needle's through the skin, the patient relaxes. So try and penetrate the skin very quickly and with a minimum of effort, and then you can try and localize the joint. And be firm and purposeful. Don't be jabbing around trying to find the joint. In and out, and avoid psychological trauma to the patient. So you want to be obviously, sepsis is a major concern if you get it. Expose the injection site properly. If it's a shoulder, make sure the patient takes the top off. Leave the brass strap on, it's not necessary. Or if it's a knee, take the pants off, leave the underpants on, so you've got the whole leg exposed, the whole area. I like to clean it with alcohol disinfectant. You can use web coils, but if you're going to use web coils, use at least 6. Make sure it's nice and wet. You may want to localize where your injection needle is going to go, because you're going to palpate first. So I may use my fingernail to indent the skin. Marker may wash off. It's an aseptic technique, not a sterile technique. So wash your hands, put on sterile gloves, or wash your hands with alcohol, make sure they're clean. And it's unnecessary to use sterile drapes. You need to document in your notes your indications for injection, document which joint you're injecting, which side you're injecting, what you're giving in the joint, and also make a note of the expiration dates and lot numbers on the medications. It's always important that you actually check it before you inject the patient. Occasionally the medicine's expired, and if there's any questions later, you need to make sure that you've actually given medicine which is up to date. If you aspirate fluid, make a note of how much fluid you have, the color, the clarity, and the viscosity of the fluid, what it is. That's all important, part of the diagnosis. The fluid you send off the lab, you can ask for a cell count in the fluid, any cultures. So the typical MCNS, a gram stain, and you may want to ask for light microscopy and a polarized light if you want to exclude a crystal arthropathy. So one of the tests for crystal arthropathy in the joint is to shine a polarized light on the crystal. Uric acid crystals are negatively birefringent, so if you shine polarized light on uric acid crystals, one color shines back at you, and this is an example of uric acid crystals which are negatively birefringent. One is seeing two colors in this slide, so this is positively birefringent, and one finds it in calcium pyrophosphate crystal deposition or pseudogout. After injection, put a simple sticky plaster or band-aid on the hole. If there's bleeding, put some pressure onto the thumb for a while, or let the patient hold it until it stops bleeding. You maybe even need a pressure dressing. Explain the patient to go home and rest. Don't forget, if you put local anesthetic in the joint is painful beforehand. If you put local anesthetic in, you're taking away the protective pain response. The patient may hurt the joint. Remember, pain is a protective thing. So while the local is in, they must take it easy, rest the joint, warn them about the local anesthetic is going to wear off and the pain may come back later, and warn the patients about a steroid flare. So looking at our relative joints which we're going to want to inject, you need to know your basic anatomy, with the knee, where the bursas are lying, and where the tendons are lying, and your hamstring insertions. So knee aspiration, knees a pretty easy joint to get into. You can do the patient lying supine or sitting up. If you supine, that's fine. You want to palpate your bony landmark, so you have an appreciation of where the patella is, the borders of the patella, and the lateral femur. Palpate the patella. You should be able to get under the edge of the patella. Nice thing about lying supine is the quadriceps are relaxed, so you can actually lift the patella. I've drawn some landmarks on the knee here, so you can get an idea where the quadriceps insertion is, also the patellar tendon, and where the lateral edge of the joint is. This would be the lateral femoral condyle, yeah? So you want to be going in this gap between the edge of the patella and the femoral condyle. So once you're palpating the lateral border of the patella and the lateral femur at the patellofemoral joint, that's where you're going to put your injection. You want to aim the needle towards the center of the knee at about 15-20 degrees towards the trochlea of the femur. On a cross section, this is the angle you're going in at parallel with the trochlea, so about 15-20 degrees, aiming for the center of the knee and the patella. And if you lift the patella up with your fingers, there's a reasonable amount of space there. A very suitable alternative to the patient supine is the patient sitting on the side of the bed and in a relaxed position like that. It's probably slightly less reliable, but in the patient's obese, it can be easier, and then be sitting with the knee at 90 degrees flexion. Palpate the bony landmarks, palpate the patella and the tibial tubercle. Put your thumbs on each side of the patellar tendon to appreciate the tibial plateau. That's the sort of edge of the knee joint. I've drawn in the landmarks there, and you get an appreciation of where you want to be going. Obviously, be mindful not to inject into the patellar tendon. You can choose to go medial or lateral to the patellar tendon. I prefer laterally because it's just slightly more convenient. You want to be going a centimeter above the tibial plateau, so you can put your thumb on the tibial plateau and go just above your thumb, and aiming for the center of the knee, for the intercondylar notch. That's your trajectory, and there's nothing really to damage in the knee. You'll never go through the back of the knee with a needle. So in a quick stabbing motion, you get the needle right through the skin into the joint in one movement. If you inject and you find that it's not going easily or the patient's got pain, just withdraw your needle slightly. You may have the tip of the needle in the cruciate ligament, and it should actually inject very easily without much ado. ITB is a very common syndrome among runners, and it's really a frictional tendinitis or fasciitis. When patients are running, the ITB is slapping over the lateral femoral condyle and causes an irritation in the bursa here. It's diagnosed on the patient having local pain over the ITB. They'll have a history of maybe running, and if you flex the knee to 30 degrees, as the fascial band slips posteriorly, it snaps over it, it causes pain. So you can palpate with the finger over the femoral condyle where there's local tenderness, and you can inject straight down onto the femoral condyle some local anesthetic and a bit of celestine or Medial. Have an appreciation of where the hamstrings insert onto the medial side of the proximal tibia, onto the so-called pes anserinus. Remember that in your anatomy years it means the duck's foot, and the three hamstrings respectively will insert there. There's a bursa under this common tendon insertion, and that can be locally tender. You can diagnose it clinically with your thumb and palpate it, and the injection is straight down vertically onto the bursa, and you give the local injection as routine. Just once again, know your anatomy around the knee, know where the various bursas are, and the most important thing is to avoid the patellar tendon. There's also a pre-patellar bursa, which is another term for it would be house paint's knee if you get a bursitis from excessive kneeling, and normally it's only potential space, but it can become very swollen and may respond to a steroid injection. Just be careful there's not a local infection. Obviously it's very subcutaneous, and there may be little boils and lesions which can cause infection. If you need, down to some blood tests, and if it's red, definitely don't inject it. But if it's just a overuse bursitis, that can be easily injected. It's subcutaneous, and it should relieve the symptoms. Shoulder is a very common injected joint, and it's various described techniques of injecting the glenohumeral joint. An easy one is the anterior approach, sitting facing the patient. You want to palpate your bone marks. Have an appreciation for the acromion and the coracoid, and those are easy to palpate even in a very obese patient. You should be able to palpate your sternoclavicular joint, acromioclavicular joint, again the humeral joint, and the biceps tendon. The rotator cuff, you can usually palpate the supraspinatus tendon, infraspinatus tendon, and the teres minor tendon. These may also be areas of pain. To inject the glenohumeral joint, the area of injection is really around here, a centimeter below the coracoid process, and just medial to the humeral head. There's no real anatomy of concern up here by the coracoid process. Your plexus is passing and your artery is passing quite inferior to that. So if you're near the coracoid tip, you're pretty safe. These are landmarks you can palpate. The edge of the acromion, there's a coracoid. Palpate these, palpate the clavicle, palpate the coracoid. You can actually leave your thumb on the coracoid to localize when your needle goes. It's been marked here in this patient. Your needle must go just lateral to the coracoid process at about a 20-degree angle. If you find the needle's not going easily, just reposition it. Most commonly, you'll be going into the coracoid, so go just lateral to the coracoid. Try to superimpose the anatomy here, so you can see once again there's a coracoid, and you're quite far from the plexus and the axillary artery. And if you go just lateral to the coracoid, you'll descend down onto the glenohumeral joint. The subdeltoid bursa is really another area of which we inject quite commonly. Just need to localize your midpoint of the acromion, and it's a centimeter just distal to the acromion, angling the needle upwards. Clinically palpate the acromion. You can feel the anterior and posterior border, and it's really almost a finger just distal to the tip of the acromion. Elbow joint is another very easily accessible joint. Once again, just be careful if you're going to inject a joint. Just make sure you do an X-ray beforehand to rule out any inflammatory or infective conditions that may need a different treatment algorithm. Examine the elbow. The lateral epicondyle is where your common extensor mass inserts. You may palpate for an Olecranon Bursa, and palpate the lateral joint line between the humerus and the proximal ulna for swelling or fusion. Injecting the elbow joint is pretty simple. You want to say lateral, palpate the lateral epicondyle and the tip of the olecranon. Exactly between those is where the joint is. You can palpate it yourself, angling the needle towards the middle of the antecubital fossa, holding the elbow 90 degrees. It's a very safe injection. There's nothing much of importance laterally, and it's a very easy way of aspirating the joint or injecting into the elbow joint. Olecranon Bursa is another subcutaneous bursa where one can inject for bursitis. Once again, just be wary to make sure that there's no local infection or cellulitis. Patients with the lateral epicondylitis, they may complain. It's a so-called tennis elbow. They'll find it's painful to grip, to pick things up. Different other treatment techniques are to put a wrist splint on to avoid moving the common extensors and the common flexors. Ice or massage, limit activities, and splint the hand. Physiotherapy may have some benefit, or using a forearm strap. And these are very commonly injected areas. You really want to inject it over the point of maximum tenderness where the patient indicates. And it's a very simple injection, and once you get instantaneous relief, which helps your diagnosis. So once again, to inject the lateral epicondyle, find the point of maximum tenderness, needle perpendicular to the skin into the muscle, and inject 1 or 2 cc's of lignocaine or marcaine with a small needle and half a cc of steroid. Once again, you can palpate the lateral epicondyle here, and it's a straight vertical to the skin injection. There's no structures of any concern laterally here. Medial elbow pain, the so-called golfer's elbow or medial epicondylitis, is tender specifically over the medial epicondyle. Be very careful of any pain, or if it's tender between the epicondyle and the olecranon. That's where your ulnar nerve runs, and that's commonly diagnosis made for ulnar neuritis. You don't want to be injecting the ulnar nerve, probably the most important nerve in the hand. So for the medial elbow pain, if you think it's a golfer's elbow, palpate your medial epicondyle, and also palpate the nerve to check that the nerve itself is not tender, inflamed. Your area's injection is going to be anterior, slightly anterior to the medial epicondyle. Moving on to the wrist and hand conditions. If there's been a history of injury, take an X-ray. Okay, a lot of the hand conditions have a lot of overlap in symptoms, so it's better off if you have a patient complaining of hand or wrist pain to do simple examinations for all the different conditions I'm going to describe here. Then you can make sure you don't miss out anything. Typical patient will be complaining of aches in the wrist, clumsiness when holding things, fingers maybe losing tactile sensation. Commonly wake up from sleeping, have to lift their hand in the air and shake it, or hang it off their bed. Do your Fallon's test, your carpal compression tests. Look at the skin for atrophy, muscle atrophy, maybe dry skin. Important to note that the pinky side of the hand is always spared, so the diagnosis is obvious. Carpal tunnel syndrome. So these patients, if they're complaining of constant tingling or numbness, you need to refer them. The carpal tunnel needs urgent decompression. Otherwise, if it's just episodic, initially you want to treat them with night splints. Activity modification, so avoid any activity they're doing with excessive use of the wrists. Non-steroidals, your main safe treatment. And injection can be, if it's done early enough, can be therapeutic, and even diagnostic and prognostic. Important in these patients to exclude neuropathy, peripheral neuropathy, or thyroid problems. If your diagnostic injections fail, you probably want to send them off for nerve conduction studies to confirm your diagnosis. With a steroid injection in the carpal tunnel, you want to use 1 ml of Medial or 1 ml of cellulestone solispan and 2 ml of lignocaine. You can inject them every 3 weeks. Expect 80% efficacy with the first injection, which then diminishes after 2 injections to 15%. By the third injection, only 5% will have benefit. Use a small needle. A little light brown needle is fine, or a blue needle. You want to localize the carpal tunnel and avoid injecting directly into the nerve, which is problematic. So an easy way to do it is to find your palmaris longus. If you clench your thumb to your little finger like that, it will show the palmaris longus, and you inject on the ulnar board, just in the ulnar board of palmaris longus. So not everyone's got a palmaris longus, and when you find you haven't got one, you can take the midline of the wrist crease and just inject just ulnar to that median axis, which is the wrist crease. Okay, so where you inject, you can inject on the distal wrist line, basically between the scaphoid and the pisiform tuberculums, and then just on the ulnar side of your palmaris longus or your median wrist crease. The point of injecting here is you're injecting directly into the carpal tunnel, and the nerve is fixed in the tunnel and probably a high likelihood of injecting into the nerve. The safe injection would be to take the proximal wrist line and you inject a couple of centimeters before that, so you're injecting the nerve before it enters the carpal tunnel. It's probably a safe injection there. angle your needle in at about 30 degrees. You can see they're using a fine blue needle here. And be very careful that you don't have any symptoms while you're injecting. If the patient complains of tingling while inserting the needle, withdraw it and try it again. And respect any resistance. It should flow easily into the sheath, the carpal tunnel at least. If it's not flowing easily, maybe in a tendon or in the nerve, and you need to withdraw the needle until it flows or inject easily. Patients complaining of pain in the wrist with aching during gripping. They may have a history of overuse. There's no numbness or paresthesia in the fingers. Often seen in young mothers. Pain is commonly over the radial styloid. And you always want to do a Finkelstein's test in these patients. So this is a diagnosis for DeQuervains Tenosynovitis, which is the first dorsal compartment synovitis. The tendons are fairly crowded as they pass through the wrist sheath at the wrist. Initially, the treatment is a thumb spica splint, ice, massage, non-steroidals for a couple of weeks. Injections work very well for DeQuervains. The first injection is curative in 80%, and the second injection takes away the next 10% of patients. So this is a Finkelstein test we've seen on the left, and a thumb wrist splint often help the pain. To localize the tendon, get the patient to actively extend the thumb, and you can see the first dorsal compartment tendons in the snuff box. Visualize where the tendons are disappearing on the radial styloid. Put the needle in at a 45-degree angle down into bone and pull it back slightly, and inject 1 or 2 cc of lidocaine with Marcaine. So here's your DeQuervains area under the tendon sheath here. Put the needle straight down into the bone and inject. So I start injecting once I'm on the bone, often in the periosteum, and it won't flow easily. As you've got some resistance in the needle, pull it back slightly and it will start to flow easily, and the patient should have instant relief of their DeQuervain symptoms. Another common complaint is the wrist, which is aching at the base of the thumb. Patients may have trouble doing normal activities of daily living, housework, chores. They have grip weakness. They feel something such as like crepitus in the thumb. There may be a visible bump. Often you find the patients have got a sort of adduction deformity of the thumb, and your thumb grind and Watson tests are usually positive. So this is a diagnosis for basal joint arthritis, 10 times more common in women. X-rays don't really match the symptoms. You may have severe X-ray changes and very few symptoms. Treat it like any arthritic process with your normal conservative treatments. Rest, ice, massage, and non-steroidals. Splints aren't very useful because the thumb is not useful in the splint, and the patients can't function with one hand. And injections are the mainstay of treatment for this condition. There's a picture of basal joint OA of the thumb, and you want to really put the needle at the base of the thumb there. Whether you truly get intra-articular probably doesn't matter. The steroids have quite a reasonable local effect, and usually that will take the pain away. If it persists, you need to refer the patient to a hand surgeon. The foot and the ankle are the last areas we're going to discuss. The tibio-talar joint and plantar fasciitis. The tibio-talar joint, you need to palpate it. It's usually localized in medial malleolus and palpate 1 centimeter anterior to it, just medial to extensor tendon, and you can also palpate just anterior to distal fibula, as shown in the picture. Needle goes in the same landmark, once again just anterior to the distal medial malleolus, and just medial to the dorsalis pedis pulse and the extensor tendon. You will find a lot of patients complaining of plantar fasciitis. It's a very difficult condition to treat. It may last for sometimes years. Patients will usually indicate the tender spot on the fascia where it inserts onto the calcaneus. Don't inject directly perpendicular to the plane of the sole. It's very painful to have injection into your sole of your foot. So you can see here the injection is usually coming from the medial side, not in the middle of the sole, and try and get down onto the bone of the calcaneus. That's where the fascia inserts. Don't actually inject the fascia itself. You don't want to have a rupture of the fascia. Once again, that can cause quite severe problems in the foot with a flat foot deformity.